We will have just a review session. Mostly we will go through the material what we have done already, and we will again do questions as much as possible. So we will discuss the clinical anatomy basically of all topics what are relevant to this block. We'll talk about the posterior abdominal wall. We will talk about kidney, ureter, urinary bladder, prostate gland, and urethra. So that's the plan, and we will start with some questions to go. So, 63 years old man comes to the emergency department with a back pain, weakness, and shortness of breath. The examination he has an aneurysm of the abdominal aorta at the aortic hiatus of the diaphragm. Which of the following pairs of the structures would be most likely compromised? The compressed. CYC. Right. Let us. Yeah, we just.
Sorry, we had a whole review, so that's why. Did you start in like?
No worries. We just started right now. That's the first question. No worries. You are good. You are in time. So anyway, that is the question which help us to review the anatomy of the diaphragm. Diaphragm, it's a border between the thoracic and abdominal cavity, but also diaphragm is important in the renal block. Why? It participated in the formation of the renal band, right? So, how many foramina in the diaphragm do we know? 3, right? The first one, the top one, say like that, will be T8, where we have just IVC, inferior vena cava. Very well. Now, the second one will be at the level of the T10 for esophagus, and vagus nerves. By the way, vagus nerves, what those nerves are? Parasympathetic, sympathetic, parasympathetic at this point. Okay. And the third one, the lowest one at the level of the T12, we focus on it in this block. That's for the abdominal aorta and right, and those structures what we are talking about. So azygous vein and thoracic gum, right? Azygous vein, that is the vein which drains from what? From the right side of the thoracic cavity and right upper abdomen. The left side we have hemizygous vein, which joined with the zygous vein. The zygous vein is just the one unpaired, so it's sitting only on the right and drains to the superior vena cava. What is the thoracic duct? Right, that is the major lymphatic duct of the body. It starts in the abdominal area from the cisterna chyli or cisterna chyli, milk cistern, and it runs all the way up through this aortic foramen of the diaphragm to join with the left subclavian angle, right? So major lymphatic duct. Okay, are we good? Right. The second question is, 27 years old woman has suffered a gunshot wound in her mid-abdomen. After examining the patient's angiogram, what the angiogram is? X-ray with a contrast which basically help us to recognize blood vessels. A trauma surgeon locates the source of the bleeding from the pairs of veins that typically terminate in the same vein. Which of the following veins are damaged? Right. Are you sure? That's correct. Now, why is that? What this question is all about? This question built upon what? On the fact that the venous distribution in the posterior wall is a little bit different compared to the rest of the body. And the difference is that the most of the veins, they are not joined IVC directly, but rather than the left renal vein, right? So, the left and right ovarian veins, what happened to them? Why they are not joined to the same vein? Correct. The left one will be left renal vein. The same we can say about the testicular. Both of them we call gonadal, right? What about suprarenal? The same. The left suprarenal vein will join left renal vein, and after that left renal vein will join the IVC. Unlike hepatic veins they drain from the liver, they both join to the IVC directly in there, but you will talk about this more details once you will learn the liver in the upcoming book, the J. Right. After removing a large portion of the left kidney in a patient with cancer, you are now examining the lymph nodes that receive the lymph from this organ. Which of the following structures receive the lymph directly from the kidney? That's correct. The lumbar lymphatic nodes, but be careful, lumbar lymphatic nodes, they do have another name, which you also have to know. What is the name? Para-aortic. So, para-aortic lymphatic nodes or lumbar lymphatic nodes would be the correct answer if we're talking about the drainage from the lymphatic drainage from the kidney, and potentially could be target of the metastasis in case of the cancer of the kidney. Okay. Next one. The parasympathetic nervous system is responsible for the bladder emptying. We are talking about the micturition reflex, right? Which nerve carries parasympathetic fibers to the bladder, promoting the trusor muscle contraction and relaxation of the internal urethral sphincter? D will be correct. Pelvic splanchnic nerves. Now I have few related questions. Pelvic splanchnic nerves, they will be pre or postganglionic? Preganglionic. They will start with the neurons which are sitting at the end of the spinal cord, at the conus medullaris. How do we call that nucleus? Sacral parasympathetic nucleus. What is the level of this nucleus? And subsequently we can say the same root value for the pelvic splanchnic nerves. Correct. S2, S3, S4. All those details are important to remember. And the last my question is, okay, pelvic splanchnic nerves will get into the bladder. Do they directly will innervate those muscles, the trusor and relax the internal sphincter?
Yes.
Are you sure? Those axons are preganglionic. So
There's still postganglionic.
yes, they have to meet to the postganglionic neurons. Where we can find the postganglionic parasympathetic? Inside of the organ. How do we call those? Terminal ganglia. Now those terminal ganglia will send axons to the trusor muscle and to the sphincter, to the internal urethral sphincter. So it's always two neurons, pre and postganglionics. Pelvic splanchnic nerves we're always talking about, it's just axons from the preganglionic. Are you clear? Again, one more time, what is the root value of these nerves? Pelvic splanchnic nerves, the root values. Root value means from which segments of the spinal cord do they originate? S2, S3, S4, right? For any nerve, root value means from which segments of the spinal cord those nerves are coming from.
So it's
right?
gonna have to be like either like L or C or
Correct.
S1.
Yeah, depending on the nerve. That's right. And root value has nothing to do with the cranial nerves. And basically, we are not talking about the cranial nerves in the renal block at all, right? Which is good, or it is bad. No worries, we will have a lot of talk about the cranial nerves in the year 2. Once we will have neuroscience of head and neck, you will get tons of information about the cranial nerves. Right now, let's focus on those which are in the pelvis. Okay, by the way, if you have any doubts, or if you have some questions, that is a good time to ask, because honestly speaking, like we have not a lot of questions to discuss. We will be done even earlier than expected, so we have time for the discussion. Okay, so the next one. You wish to examine the hilum of the right kidney during surgery, okay? Or which of the following structures must be elevated and reflected to do so? Right, the correct answer will be duodenum. This question is basically about the relationships of the kidneys, right?
Yes.
What could you tell me, what is sitting behind the kidneys? the muscles. How many muscles do we have behind? 4. How do we call those muscles?
Psoas major, iliacus,
Psoas major, quadratus lumborum, iliacus. Iliacus has nothing to do. Okay. So again, one more time. Behind the kidney, the renal bed, we have 4 muscles. Number 1,
psoas major,
psoas major. Number 2,
coronaris lumborum,
quadratus lumborum. Those 2 are major, but we also have 2 more. Diaphragm and right, transversus abdominis muscle. Those we have behind. We call them collectively renal bed because once we lie down in the supine position, the kidney will rest on them. Okay? Now, what do we have on front? Yeah, correct.
organs,
Internal organs, most of them they are belonging to the GIT. Kidney is sitting in which position in relation to the peritoneum? So behind of the peritoneum, in the retroperitoneal position, right? Now, do they have the similar organs, left and right kidney?
no,
They do have different, right? So what do we have on the right side?
the
The
liver,
liver on the top.
The third part of
on
the
the top we
duodenum.
have suprarenal gland. We have the liver. We have this one.
third part of the
Right. We have the second part, horizontal part of the duodenum, and we have underneath what? Something else? The colon, right? Now, but why duodenum we are focusing on? Because of the practical reason, right? So once we do the nephrectomy, what the nephrectomy means? Kidney removal, right? So once we remove something, the first step to do, ligate blood vessels, right? And in order to ligate the blood vessels to the kidney, we have to access which part of the kidney? Which part of the kidney? Hilum of the kidney, that's why. So we have the different approaches for the nephrectomy. We can do it from behind or we can do it from the front. So if we do it from the front, we reflect the peritoneum and we are getting to the hilum of the kidney, we ligated blood vessels, and only after that remove the kidney. Are we clear? What do we have on the left side? We are talking on the right side. What about the left side? Spleen, stomach, pancreas. Right. Now, which one will be related to the hilum of the left kidney? Pancreas. Pancreas mostly. Yeah, pancreas will be the most one because it's sitting in the middle. Right. Now, next one. Again, during the removal of the patient's kidney, how do we call this again? Nephrectomy. You would observe which of the following has been most anterior within the renal sinus. So we are getting to the renal sinus and we are looking on the structures sitting in the renal sinus. Say it again. Correct. Why is that? What do we have in the renal sinus?
have renal veins and the arteries and the ureters.
Right. And this sequence is
Anterior.
anterior to posterior. Okay, very well. And what happened to the ureter? Is it going up?
Down.
It's going down. Very well. Okay, one more question. So we call this place, how do we call this place? Renal sinus. So we have the inner, so the kidney pin shape, right? The inner medial border we call, has what shape? Concave shape. The deepness over here we call renal sinus, right? And the entrance of the blood vessels and exit of the ureter we call hilum. Are we clear about the terminology, right? Very well. 59-year-old woman comes to the local hospital for uterine cancer surgery. As the uterine artery passes from the internal iliac artery to the uterus, it crosses superior to which of the following structures, which sometimes mistakenly ligated during such a surgery? Correct. Very true. Now, could you tell me which surgery we are talking about? Hysterectomy. Very true. Now, the ureter and uterine artery both are sitting very close inside of which ligament of the uterus? cardinal ligament. Cardinal means the main one. It's sitting on the lateral aspect of the uterus. That's the only ligament will be mentioned. The rest of them you will learn later on. And only be mentioned because of the location of the uterus and uterine artery. So the uterine artery passes superior, right? What about ureter? What if we will compare ureter to the uterine artery? What will be position of the ureter? Posterior and inferior, from behind underneath, right? The water under the bridge. Are we clear? Right. Now, a step wound immediately superior to the pubic symphysis through the anterior abdominal wall would most likely injure which visceral organ first? Blood. That is very true. Again, so, no, from the options, that's the only option, right? But if we look carefully on this question will be correct if we're talking about children, right? But if we're talking about adults, it depends. If the bladder will be full, yes. If the bladder will be empty, not exactly. So it probably will be some abdominal viscera, like loops of the small intestine, or greater omentum, or something else, right? So it should specify that the bladder was full, but how do we know, right? Anyway, but options are clear. That's the beauty of the MCQ, right? No doubts about this. There is no small intestine in the option, so you're supposed to pick up what is the best. Right. During prostatic surgery, the nerves that innervated the prostate are damaged. Due to that, the patient has erectile dysfunction. What of the following is most likely to be seen in the patient else? Right. That is very true. Again, that's a good opportunity to revise this conception. How do we call this surgery? What we are talking about? What kind? Right, prostatectomy, right? We're talking a lot about the ectomy in this block, so prostatectomy, the surgery. So once we remove the prostate gland, basically the nerves inside could be damaged. What nerves are inside? Inside of the gland. We have branch from the pelvic splanchnic nerves, but not the pelvic nerves itself. Mildew. How do we call the branch of the pelvic splanchnic nerves, which is also parasympathetic, which specifically runs through the prostate gland to the penis and cause an erection? We call them cavernous nerves. Okay, so cavernous nerves, those which will be specifically responsible for the erection. Now, cavernous nerves, they could be damaged by any surgery in the prostate gland, including the minor one, what we call transurethral prostatectomy. That's what we are doing in case of the benign prostatic hyperplasia, right? But if we're talking, it also causes the erectile dysfunction, right? But if we're talking about the major surgery, when we remove the entire prostate gland and underline the, like venous plexus as well as the lymphatic nodes around, that's the time when the pelvic splanchnic nerves could be damaged. So in case of the radical prostatectomy, which probably was the case over here, because the radical prostatectomy is much more traumatic. Not just the erectile dysfunction, but since we damage the pelvic splanchnic nerves, they have another branches going to the abdominal viscera, right? So in this case, we are talking about the lack of sigmoid peristalsis. But, okay, two questions. Question number one, is it just specifically colon sigmoid will be affected or something else could be in the options instead of the colon sigmoid, instead of the sigmoid? We can put two more other options and it will be correct. Rectum will be correct, and also colon distended, colon sigmoid, and rectum. Three of them belonging to the hindgut derivates. We will learn this later on. Those three will be innervated by the pelvic splanchnic nerve. So I could change the sigmoid on any. I'll or rectal or colon descending, it also will be correct. Are we good? Right, now lack of this peristalsis. What would be the clinical sign? I mean, like constipation, right? That would be constipation. Why? Because peristalsis actually move fecal masses through the large intestine and cause amplification. Are we good? Right. What the incontinence means? Like rectal incontinence means quite opposite. When the patient cannot hold. Okay? Anyway, 41 years old man is unable to urinate because of the contraction of the internal urethral sphincter and weakness of the trusor muscle. This condition may occur as a result of injury of which of the following nerve structures? Correct. Pelvic splanchnic nerves will be the correct option in this case. Again, we talked about the pelvic splanchnic nerves, right? So you need to know the root value, you need to know where it's coming from, the preganglionic, postganglionic, that's okay. But tell me, if we will cut the pelvic splanchnic nerves, which is the parasympathetic, correct?
Yeah.
So what happened, why exactly the internal urethral sphincter will be constricted? Constricted, it means not relaxed. Why it will be constricted? We cut off the nerve, but the sphincter is constricted. Why? Because of sympathetic, right? There's nothing saying about the sympathetic. Which sympathetic nerves will supply the sphincter? Sacral splanchnic nerves, which could be sympathetic. Are we clear about this? So that's exactly what sacral splanchnic nerves are doing. They constrict the sphincter and they relax the trusor urine muscle. Okay. Now we are coming to the point where we will have like discussion with you, not by the MCQ but SAQ. So that's a picture of the posterior abdominal wall from the atlas. So what do we have over here? I will point, you will tell me what it is, okay? Is this better, no? No. So, like this. Okay, anyway. So what it is? Good. Hepatic veins, we talked about them. Now this one. Right, gonadal vein. Very well. This one. Which one? Right ureter. Left ureter. Bifurcation of the abdominal aorta, level of the L4 very well. Rectum. Bladder. Right, this one. Genitofemoral nerve, that's the only one which pierces this muscle. How do we call this muscle again? Psoas major muscle. How do we call this one? Iliacus. How do we call this one? That will be transverse abdominis muscle, right? That will be quadratus lumborum. That will be okay. 3 foramina you can see, right? That will be aortic. What we will focus on. That's it, pretty much, right? Did I miss something? I don't think so. Okay, so plenty of questions to discuss. We'll go briefly. So, what is an abdominal aortic aneurysm? What the aneurysm means? And why does it happen? Because of the weakness of the aortic wall. If aorta is a strong blood vessel, but if in some place will be weakness, that place eventually will dilate, right? So the most common locations for the aortic aneurysm, you know, the thoracic aortic aneurysm after the third branch of the arch of aorta, and the second, actually the most common one, will be right above of the bifurcation, L3, L4 in the abdominal aorta. Okay, what is the vertebral level of the major branches of the abdominal aorta? Let us be back to this. Major branches of the abdominal aorta. Right. That will be a celiac trunk again. T12. Very well. The next one will be. That is the one. Superior L1. Urinary arteries L1, L2, but we are focusing on the L2 just to, you know, to make a difference. But basically, you see they are very close. Oh, okay, what else? Right, that will be inferior mesenteric, will be L3. Speaking about the gonadal, their location varies, so they never ask exact origin of the gonadal arteries, but the good news is both they originate from the abdominal aorta, right? And what do we have at the level of the L4? Right. Now, if we will draw the like horizontal or axial plane through the bifurcation of the aorta, so behind we will have L4. What do we have on front? I mean, like, what key landmark will point to the bifurcation of the abdominal aorta? Where do we have it? Okay, that's a JD. Don't get confused, that's fine. Right, now, which vein, right gonadal vein drains to? IVC. What about left? Very well. That's it. Which external anatomical landmark lies in the level of the abdominal aortic bifurcation? Umbilicus. So your bifurcation of the aorta is sitting right behind of the umbilicus, basically. Right. Which is longer, the left or right renal veins? And why? And the left renal vein crosses IVC where? On front or behind? Anterior, on front of the IVC. Okay. The lumbar plexus lies within which muscle? Psoas major. What the lumbar plexus is? The ventral rami of the L1, L2, L4 spinal nerves. They do the lumbar plexus, and the lumbar plexus along with the sacral plexus participating in the innervation of the lower limb, right? Just mentioned some nerves which are running from it in this block. And what would be the two largest branches of the lumbar plexus? Femoral nerve or femoral nerve and obturator. They both have the same root value. What would be the root value? Right, L2, L3, L4. For both of them, in the MSK you will learn the difference, but right now that's okay. Those two major branches. Which two nerves arise from the L1 segment of the lumbar plexus? Very good. Iliohypogastric and ilioinguinal. How do I say another way arises from the segment? I would say, what is the root value of those nerves if I want to know where they came from? Very well, you know this very well. Which structures are innervated by the ilioinguinal nerve and iliohypogastric? Right. And cutaneous areas, right? Which dermatoma I could ask you? Tricky question. Dermatome. Level of the dermatome. L1, of course. I said the tricky question. If it is a wide level of the spinal cord, it will be L1 dermatome, no doubt about this. Okay. Which nerves arises from the L1 and L2? Genitofemoral nerve. Very well. Right. The kidneys normally lie at approximately what level? Correct. And once we are saying a level of what? We are talking about the vertebral levels, right? So once we say T12L3, we are talking about the level of the vertebral bodies. Because you know, like those numbers, they may relate to many things, like to the vertebra, to the segments of the spinal cord, to the say, spinal nerves. All right. Are the kidneys retroperitoneal or intraperitoneal? What does it mean? Right, they are sitting behind of the posterior sheet of the peritoneal, parietal peritoneum. So we have the retroperitoneal space. Mostly they have their blood vessels, kidney, and fat tissue, which basically fill up the space. Right. Okay, the kidney lies on the close association with which muscles? Yeah, we already mentioned those four muscles will be the correct answer for the renal bed.
Any answer from the four muscles would be accepted.
Say it again?
Any answers from the four muscles would be accepted.
Yeah, if you will be asked one muscle, you could choose any one. If you will name, you will be asked name all four of them, you should name all four of them. If you will ask like name any two muscles, you can choose whatever. But the best option, if you will be asked to choose two muscles, that will be psoas major and quadratus lumborum muscles. Those will be the best. Right. What is the name of the capsules that surround kidney? Capsules as a plural, right? So renal capsule, how do we call it? The fibrous renal capsule, right? Next one will be perinephric fat or perirenal fat and renal fascia. Also we call this fascia of the rod, right? Okay. What is the name of the kidney's medial concave march? Hilum of the kidney. What arteries supplies the kidneys? Renal arteries. They originate from? Both of them. Both of them originate from the abdominal aorta, correct? Good. Name three structures that enter or leave the kidney at the hilum. Right. Renal vein, artery, and ureter. What is orientation of these structures? Talk a lot about this, right? Correct. Anteriorly located vein, after that artery, and after that ureter. Trace the flow of urine from the nephron to the blood. So the last component of the nephron will be what? Collecting ducts. They will be open where? In the papilla of the renal pyramid, and urine will be collected by minor calyx. After that, major calyx. After that, right. After that, ureter. After that, and after bladder, urethra. Very well. Now, which layer immediately surround the kidney and most likely restrict the hemorrhage? Renal capsule, right? Hemorrhage, what it is? Bleeding, right? So bleeding, internal bleeding. Very well. What is the most typical place for the location of the Stark-Horn calculus? Renal pelvis. Along with the calyces, calyx minor and calyx major. Right. Male and female pelvis. Again, I will point, you will name. All right, let's play this game. So, what is that? Pubic symphysis. That will be bladder. That will be vas deferens. Keep in mind, vas deferens is coming from the testis, no, not the testis, epididymis, more correct to say, from the epididymis and testis are sitting in the scrotum. So vas deferens is a long tube, like 25 to 30 centimeters. So it runs over here above of the scrotum, coming through the inguinal canal, inside of the abdominal cavity, and after that goes back again close to the bladder, and finally we can find it behind the bladder, along with which organ? No, behind the bladder. Okay, we have a bladder, we have a rectum. What do we have in between? Behind the bladder immediately we have vas deferens and seminal vesicles. That's the question what I'm looking for. Behind the bladder we have vas deferens and seminal vesicles, and after that we have a rectum. And those two seminal vesicles, A and vas deferens, will join their ducts, will join together to make right, which is sitting. Can we see it? We cannot see it because it's sitting in within the prostate gland. Okay? Alright. Now, what is that over here? Urogenital diaphragm. Which muscle do we have around skeletal? Which nerve will supply it? Pudendal nerve. Now, how do we call the muscle of the urogenital diaphragm, which is sitting around of the urethra? Are you sure? External urethral sphincter. That's the name. Which nerve supplied again? Pudendal. Will pudendal constrict or relax the sphincter? Both. That's the somatic nerve. You can voluntarily relax or constrict skeletal muscles, including this one. Okay. What the location it is? Internal urethral sphincter. Internal urethral sphincter is sitting where? In the neck of the bladder, above of the prostate gland in the male body, right? Which nerves will supply it? Parasympathetic, which will relax, that will be pelvic splanchnic nerve. Sympathetic, which will contract, sacral splanchnic nerves. The quite opposite relationship will be to the muscle inside of the wall of the bladder. How do we call this? The trusor urine muscle. Now, how do we call this part of the urethra inside? Prostatic urethra. How do we call this most narrow part? And the longest part we call penile, or we call it spongy urethra. So, good enough about males, now about females. What is this? Right, that will be, and specifically, cervix of the uterus, that will be vagina, and those two, cervix of the uterus and vagina, will be where in relation to the bladder? Posterior to the bladder, and posterior to them we have rectum. Very well. How do we call this canal? Urethra. How many sphincters do we have in the female urethra? The same two, and location will be the same. The inner sphincter is sitting over here in the neck of the bladder. Internal urethral, involuntary sphincter. How do we call this structure? Urogenital diaphragm. You can see in the female body there are two foramina in the urogenital diaphragm. In the male body, just one. So, inside of the urogenital diaphragm, around of the urethra, we have external urethral sphincter. Again, will be narrated by pudendal nerve. Any questions about that? Right. Okay. Could you identify ureter in those images? What it is? That will be female ureter right over here, and that will be ureter in the male body. Are we clear? Right. Describe the course of the ureter from the kidney to the blood. More specifically, what would be three parts? Ureter. What would be three parts of the ureter? Abdominal portion, right, and intramural or inside of the wall of the bladder. So three portions. Which will be the longest one? Abdominal, of course. Now, what would be three constrictions? Pelvico-ureteric junction. Second constriction. Pelvic rim. Third constriction in the wall of the bladder. Very well. When do the following structures open into urethra? where the ejaculatory ducts open into the male urethra. Yeah, but specifically. So in the prostatic urethra, which has the spindle shape, where we have the opening of the both ejaculatory ducts, how do we call this place inside of the prostatic urethra? We have enlargement, what we call seminal colliculus. So seminal colliculus, which is sitting on the posterior side of the prostatic urethra, we have opening of the both ejaculatory ducts. What about the prostatic ducts? Prostatic ducts, they are ducts from the prostate gland itself, right? They are opening in the prostatic urethra around, so from the both lateral sides on front, so pretty much everywhere. They are small ducts, right? Okay. What are the three parts, three constrictions and three dilations of the male urethra? Let's start with the parts. First part we call prostatic urethra, and what do you know about the prostatic? Why? The second part, which will be narrow, is the most problematic during the catheterization, and the third part will be spongy urethra or penile urethra, which will be the longest one. Three constrictions. Where do we have constrictions? Let's start either from the external or internal urethral orifices. Let's start from the external. External urethral orifice, that's the glans penis, right? We can see it basically, we can put catheter there. So the first constriction will be here. Why? Because around of the external urethral orifice inside of the glans penis, we have the fibrous ring, which basically delimit the diameter. The second constriction will be what? So catheter pass through this. The second constriction will be membranous, the most problematic part. Why? And why it is narrowest? Which muscle? External urethral sphincter, the answer I'm looking for. And after that, catheter will go up through the prostatic urethra, and the third constriction will be internal urethral sphincter in the neck of the blood. Three dilations. The first dilation will be inside of the glans penis, navicular fossa. Inside of the glans penis, navicular fossa. Now we move in catheter and into the end, or more correct to say, bulb penis, right? And in the bulb penis, we have the bulbar fossa. And after that, we are coming up to the prostate. Prostate part of the urethra will be the third dilation itself. Are we clear? Right. Okay, we just answered during the procedure of the urinary or catheterization, what portion of the urethra is the most susceptible to the membranous part? Why? Narrowest and the most problematic to pass catheter through. Very well. What is the most likely location of the prostate nodule if it is found by the digital rectal examination? A little bit tricky, but so if we use the digital rectal examination, we put the finger through the anus, we palpate the anterior rectal wall. Through the anterior rectal wall, we palpate which part of the prostate? Posterior lobe of the prostate gland, right? Or we can say peripheral zone. So that will be the most correct answer to this question, because if we palpate it, it means it's sitting behind. Does it make sense?
Yes.
Right. What is the most likely complication of the prostatectomy procedure when the prostatic nerve plexus is injured? Now, prostatic nerve plexus, little bit tricky. Let us don't get confused. Prostatic nerve plexus, another way to say cavernous nerves inside of the prostate gland. So if the cavernous nerves inside of the prostate gland are damaged, what happens? Erectile dysfunction will be the obvious answer. What are the most common sites of the metastasis of the prostatic carcinoma? Where the metastasis we can find? Correct. In the brain and vertebral bodies. The answer will be there. But of course, you need to know details how the metastatic cells get through the venous prostatic plexus, sacral veins, and after that vertebral plexus. And that's it. Enjoy this painting from Dr. Elena. Unfortunately, she cannot be here, but she says hello to you guys and she wish you all the best in the upcoming exams. So she trusts you and she says you will do well. So, yeah, inshallah. All right. Do you have any questions for me?
Yeah.
Go ahead.
I think it's the slide before this. There was a question about Niat Ward for here.
This one.
Yeah. What is the name of the kidney's medial concave margin? It's the high, and why can't you say the renal sinus?
Good question. The renal sinus is not the border. In the border we have hilum, which literally means door. But once we enter through this door, inside of the empty space in the kidney, that would be the renal sinus. You get it? So the hilum is the door. The room after that, that is the sinus. They are very close, but there are some differences. Are we clear? All right. I wish you all the best.